everybody. Glad you're here. It's me. I can first thing in. I know, and especially if you're conditioning on a nice hot day. So thank you, Megan, for having a nice full accommodation here. Anyway, we are very fortunate to have Dr. Furlong here. She is amazing and she's very personable. With touchy subjects, obviously. So she's very good at what she does. She completed medical school, internship, and residency at University of Illinois. She her fellowship was at Illinois, also in urogynecology. Dr. Furlong strives to fill a void in the healthcare world with the purpose of providing a safe, compassionate, patient-focused environment to empower women to live happier and healthier lives. She is double board certified in female pelvic medicine and reconstructive surgery, obstetrics, and gynecology. And she founded the Chicago Center for Women's Health. And she has an office in Moran on 95th Street and Bedford Park on State Road. So thank you, Dr. Furlong. Do we need the lights down?
Okay, so hi everybody, thank you for coming out. I'm so familiar with you. Okay, so normally when I do my lectures, I have props. So last time I did a lecture, one of my participants told me they couldn't do the props. I don't know the props I'll say, but if I was to do that again, I'll bring some. Because some of this is really nice to see visually when we talk about prolapse. Besides that, let me start with some little things I brought. Because I love little trinkets, and there are pens there. And these pens have little hand sanitizers. And if afterwards, I'm going to show you how you can take a little hand sanitizer out and actually fill it. Sorry, probably think what's wrong. I can't do this again. I would have to show you afterwards. And it gets refilled and you can like spray people. So they borrow your pen, they give it back. Anyway, they're up at the front. It's my little fun stuff to give away. It's good for COVID. We're still experiencing COVID. So welcome to a lecture on prolapse. And I'm Dr. Furlong. I have a practice, the all-female practice, obviously. This prolapse is a condition that only occurs to women. And this is a very interactive lecture. If anybody has a question, if you're too shy to raise your hand, just save it for the end. But I like a lot of questions because then it really makes me understand, where I need to talk and what is really important, what you don't understand. And sometimes if you save the questions for the end, which is okay too, then you might forget, right? And so it's important that I'm really clear and that you understand all the concepts. So what is prolapse? And I'm sorry if this is a little small, but I think everyone can read it. If not, obviously I'm going to be saying it. It's a bulging or falling out of a body part. So everybody is familiar with a hernia on the belly button, right? Everybody's looked at somebody and they said, oh, I have a belly button hernia and I'm going to the doctor. They're going to operate. They're going to fix the little bulge that's coming out of the belly button and they're going to make that belly button bulge go back in. So that happens in the vagina. Things bulge, things fall. And that's what prolapse is. So what causes prolapse? Prolapse can be caused by childbirth. The larger the baby, the more common that your prolapse is. Some women, even if they have C-sections, they end up with prolapse. Multiple babies can have prolapse. Constipation. So there's a condition, and it's I have it on the next slide. Okay. So with constipation, you have a lot of pushing and bearing down. If you can't have a bowel movement, you have to strain. Imagine you're holding your breath, you're closing your airway, and you're pushing down to have that bowel movement. Constipation, that constant bearing down makes part of the vagina fall. Why is that? That's because the vagina is an opening, right? How you have an intercourse with how a baby comes out, right? That opening between the pubic bone and the backbone, right? that opening is a deficit. If I had an opening here in my belly and I constantly sneezed or coughed or pushed down, something would eventually come out of that little hole, that little opening. The same thing with the vagina. The vagina is inherently an opening and a deficit structure in a woman's body that, under the wrong circumstances, can cause a dropping of an organ, the uterus, the bladder, and the rectum. So when you're constipating, you're holding your breath, and you're constantly pushing down, that opening opens more and things tend to fall. Right? A chronic cough, the same thing, right? You're coughing, you're bearing down, you're pushing, that opening opens. Now, I know that most people here can stop and say, oh, if I hold my breath and push, I can feel that pressure in my pelvic floor. I can feel things move. The heavy lifting, same thing. If I'm going to walk over and I'm going to bend over and pick something up, a lot of people hold their breath to do that. It's just kind of like a habit that puts pressure on the pelvic floor. And this holding breath technique is really important because I'm going to talk about it a little bit later. The holding breath and bearing down, whether you cough or you have constipation or you're lifting heavy, all cause pelvic muscle strain, just straining. Let's say you're having a baby. Some women push to pee, all sorts of things. And then genetics. Sometimes you just have bad tissue, right? The collagen in the tissue. You know, everybody wrinkles differently, right? Some people lay out in the sun and never get a wrinkle. Some people go out in the sun and they have wrinkles, right? Because that's because our structure of our skin, the integrity and the strength of it is different from everybody. Whether it's genetics in terms of race or it's genetics in terms of your family, everybody has different stretchiness and elasticity to their skin. And then age. Prolapse really, as you get older, it's more common. It doesn't mean that you have to be older to get prolapse. It just means that I'm not going to be really treating a 15-year-old or a 20-year-old. I'm more than likely to be treating someone who's 60, 70, 80. What are the symptoms? You have pressure. So today I had a 39-year-old young girl who came to me. And she had already seen a couple of different physicians, and she said, I just know I have prolapse, and I feel all the pressure, I feel the heaviness. I feel like when I get up and I walk, that there's something that's opening and pushing. That's the pressure. And so, I'm sorry for guys, because you're not really understand this, but for the women in my audience, and it's that opening of the vagina just feels like it's opening and something is coming through. It's a heaviness, it's a pressure, it's a ball. Some women sit down on the toilet and they look down, and there's something between their legs, and that's prolapse. Whether it's your bladder, your uterus, your rectum, you've had a hysterectomy, and sometimes it's the whole vagina. What else do patients come in? Sometimes they come in and they say, I have really bad back pain. I have lots of pain in the vagina. I can't have intercourse. It's uncomfortable to have intercourse. When my partner and I go to have intercourse, it feels like something is blocking the opening, and it's very painful. Some women come in, and because they have prolapse, they have to have incontinence of urine. The bladder starts to bulge. Okay. Some women can't empty their bladder because it's hanging out. And if that bladder, it says, bladder is like a balloon, that ball, that sac that's holding the urine, if it's descended, I always think of the ball for like New York, New Year's Eve, the ball comes down. I kind of like to remember that when I think about prolapse. And as that comes down, the urine doesn't go up to come out. Nothing jumps up to come out, right? So when you start having some retention, you can't empty completely. So it might start leaking. You might have urinary tract infections because all the urine doesn't come out. Other symptoms, this is continue. You might have bleeding. Imagine if I walk around all day with my tongue sticking out. Okay, they don't get to see that at home, right? With my tongue sticking out all day long, right? It gets dry. My tongue is supposed to be moist, right? It's supposed to be inside my mouth, right? But if I left it hanging out all day long, and I rubbed it against some cotton garments, my panties, right? But of course, it's my tongue. I start getting breakdown on my skin. So when women have prolapse and it's hanging out, and that moist skin is constantly touching a cotton garment, it starts to break down, it shakes, it bleeds, it's uncomfortable, it's painful. So the common symptom would be bleeding, and that bleeding continues, you get ulcers. I think of it like this. I took my elbow and I rubbed it against the wall all day long. You look at my elbow and I would have a sore. I would have worn away the skin on my elbow. If the vagina is hanging outside of the body and it's constantly rubbing up against garments, it's going to start breaking down. The vaginal skin is like the skin on the inside of your mouth. It is not like the skin on your arm. Okay, it's soft, it's moist, it's meant to be inside and covered. And so when it comes out, it's just, it gets dry and it cracks and it bleeds and it's painful. Okay. You can have an inability to poop, right? Because you have a rectus still where the rectum is coming out, then sometimes the poop can't come out the same way the urine can't come out. It's hanging out. So some women have to split. Splitting is when a woman takes her hand and she puts it on her vagina and then bears down and the poop can come out. Very painful and very embarrassing and hard to kind of tell somebody about that. But a lot of people don't present that way. You know, painful intercourse, again, there's a bulge, there's a blockage, things are stretched, right? And so it's uncomfortable to have sex. What are the types of prolapse? So we have inner pelvic floor from the front to the back, starting with the bladder, the uterus, and the rectum. The intestines are up in here. So any of those can bulge, right? So I use the analogy of a belly button, right? You notice you can see a little bulge in the belly button. Some babies have that. A lot of people see babies with their little part cut and a little bulge. And the mom puts a little tape and a little binder so the baby doesn't grow with the belly button hernia, right? But that happens in the vagina. Remember, the vagina is an opening. It's a circle. Things can fall through, right? So people say, well, you know, when you look, it's pink and fleshy. How do you know it's my bladder? Right? Because it depends on the direction. In the front is your bladder, in the middle is the vagina and the uterus, and in the back is the rectum. Now, if I did this, and I'm sorry for Zoom people at home who can't see, but who tells me what this is? What's pushing on my cheek here? Right, but you see my tongue? But you know it's my tongue, right? So when you look at the vagina, you see that bulge. Something behind it is pushing it. Whether it's the bladder that's pushing it, or whether it's the rectum that's pushing it. And then, of course, the physician or nurse practitioner or provider will use instruments to examine the vagina to tell which compartment it is. Does it matter? Sometimes it does matter, because it's going to make a difference in the treatment that we give the patients, right? You know, if a patient comes in complaining of urinary symptoms, I'm going to think they have more of a bladder or cystic guilt, right? Or they might even have a whole uterine prolapse. So the classifications, obviously I can push my tongue out a little bit more, and a whole lot more, right? So your bulges can get bigger. So I have patients come with my office and they think they have a cancer growing down there. It's a big bulge. Now, their uterus and everything else has come out. So you can have a grade 1. That means that a woman will put her legs up in stirrup, and when you look at the vulvar area, you don't see anything bulging out. When she holds her breath and pushes down, you don't see anything. Without using instruments, just with visual. I part the lips, I look, and I don't see anything coming out of the vagina. A grade 2 is moderate. It kind of sort of comes to the opening. You might or you might not see something, and the lips of the labia of a woman might part a little bit. A stage 3, it goes to the opening, you part the lips, and you see it there, or it comes out a little bit before. So technically, stage 3 is just a little bit inside of the opening, just a little bit outside. It can be variable. And then a 4 is you sit down and it's just there, right? So I've had patients who had this, and they have a normal exam when I examine them. Dr. Furlong, I took a picture. I knew this would happen. Yeah, I didn't do anything for something I don't see. Why? Because sometimes they have a job where they're really active. Maybe they're a home health caregiver, and there will be someone, right? So you're straining. Sometimes you're a nurse, and you're helping patients move, and so you're pushing, you're straining. I have a lot of nurses. I have a lot of women who clean homes. They're lifting up the mattress, they put the fitted sheet under, they're picking up the garbage, they're mopping with a heavy mop. I have a lot of moms who had a few babies, they're going to Costco to save some money, and they're buying big cases of water and they're putting them in their SUV, right? So all of these things affect the pelvic floor. And you know, us women, we don't let guys do anything for us, you know? And one, we do it faster, two, we do it better. But it takes its toll, right? Our vagina ends up with one of these things happening. And once it's broken, it doesn't come back. A lot of my patients are like, I'm gonna go to physical therapy, and I'm gonna do Kegels. I'm like, go ahead and do that. We'll come back to you in 6 months and we'll talk about treatment. It just doesn't come back. Can it make you more comfortable? Yes. Can it alleviate some symptoms? Yes. But a stage 3 is never gonna go back to normal. Tissue doesn't really like shrink back, with one exception, and I'll talk about that later. So these are kind of the classifications. So again, as you look at the vagina, you know, patient might not know what part of their vagina is coming out. And secondly, it doesn't matter because it's really based on what the patient feels. I do health exams all the time where I see some prolapse on a whole patient. Oh, you know, I see a little bit of bulging. Does this bother you? No, it doesn't bother me. Okay. And sometimes I have patients who come in and they say they have prolapse and I don't see it. So you have those people stand up, you have them jump, you have them bear down, you tell them come back and see me at the end of your day. After you've been working 8 hours on your feet, for UPS, moving boxes, getting in and out of your truck or FedEx, whatever you're doing, and see me, right? And then we'll see where you're at, right? And then you can diagnose it. And sometimes it goes back up, kind of like a little bungee cord. But for the most part, it's very uncomfortable and does hang out, right? It comes down. Sorry, let's skip this. So, exams and tests. It's all visual. You know, it's like a pap smear. It's kind of cute with a lot of my older patients that come back and see me. And they're like, what are the results of my pap smear? I'm like, I don't do a pap smear. They're like, well, you look at this. Like, no, we don't do a pap smear every time we look. They're like, oh, okay. So I have to remind everybody, just as we do an exam doesn't mean a pap test is done. We look for other reasons, right? We look for diagnostics. We want to look to see if you have sores, bumps, lumps, cancer, what's coming really out, right? You know, are you bleeding because, again, like the tongue is hanging out all day and it's chafed and dry and cracking, or are you bleeding because you have a cancer in the uterus or the ovaries, right? What are you really bleeding from? So we do exams, you know, and we want to look, we want to see what's happening. Are you in pain? Is it uncomfortable? Can it be reduced? What does the opening feel like, right? Because there's a difference. Even though you have prolapse, which is a very interesting thought, more for the clinician than for the patient, because it decides your treatment option, depends on what's coming down. Now imagine if you have an opening, it's a circle, right? And it has this diameter, right? So it's tight, or whatever, it's this diameter. Now you put a bowling ball on it, right? And you carry it around all day. Eventually, it starts to stretch and open. It's not that size anymore. That diameter has increased. So as you have prolapse and you have constant pressure on the opening stretches. The more that the opening stretches, the worse your prolapse will get. And the faster your prolapse will progress. Okay? So you have to look at all the compartments of a pelvic floor. So it's mainly just looking and doing an exam. When we look at function, here we go. Let's say a patient presents with bladder problems. We talked about incontinence, we talked about recurrent urinary tract infections. Just for bladder, you can look in the bladder with the camera, right? Because you want to make sure that it's not just the prolapse that's causing these problems. You want to make sure it's not a cancer. Although cancer in the bladder is very uncommon in a woman, I do see it, and I see it in young patients too. I've diagnosed a few, so it's something you definitely want to do. And I always laugh. I tell my 49-year-old, oh my God, you're so young. I'm not going to fight cancer until one day I found cancer, right? And it was a bad cancer. So you want to look, you don't want to, you know, it's in the textbook, it's protocol. You got to have it done because it's going to change that one person's life and it takes a minute to do it. It's a simple office procedure. Urodynamic testing, maybe the patient has incontinence or incomplete bladder emptying, and there's a couple of reasons because if I'm thinking of surgery, then I want to know how their bladder functions, because then I have to counsel them for their surgical option and their post-operative care, okay? Sometimes we do ultrasound or catheter, and we look and see, is the patient really emptying their bladder, right? Try not to do that too much. I try to piggyback that with ultrasound, just so that I kind of get two for the price of one, and my patient's comfortable and I'm not catheterizing them. The urodynamic testing requires a catheter, so it's a little more invasive. I really try to save that for my patients who I want to do surgery on. But if I'm not going to do surgery on my patient, I don't really care how they leave it, because I'm not going to treat it. So I don't make them go through an invasive test, you know, that they have to pay a copay and things for if I'm not going to do something about it. Treatment options, observation, right? We looked at those 4 stages, right? You have a little bit, you have kind of a little bit more, you have it where it's coming to the opening and where it's hanging out, right? It's hanging out, you don't get observation, right? You have to do something about it. So, but some people really you can observe, right? If it's a stage 1, stage 2, and it's a patient who really has the pelvic floor muscles or is highly motivated and wants to go and go to physical therapy, change their constipation, change the way they live. Remember, I talked about holding your breath and bearing down. That causes prolapse. We want to teach people how to stop holding their breath and bearing down, right? So everybody can go home tonight or tomorrow and you can try to poop without holding their breath. You don't have to tell me, you don't have to write me, but it would be very interesting when you're sitting on the toilet and thinking about Dr. Furlong, and you're saying, oh my God, it's so hard to poop without holding my breath. Yeah. So that's a bad sound. That's what causes prolapse. So go home, sit down, and be like, oh my God, never realized I had to do this. We can do piece by fiber, which we'll talk about later. Okay. Kegel. So Kegels are the poor man's treatment. Which is not bad. You can pay a lot of money to go to physical therapy. But remember, I already told you guys it's broken. You cannot fix broken with Kegels. It's surgery, period. And a pastry, there's another thing. But you're not going to go and like strengthen your pelvic floor muscles and, you know, do your hands on your knees and get that Susan Summers, I don't know, people on TV showing people, you know, even she moves out of her legs. None of that's going to work. So spend your money, don't waste your time. Your tissue is broken and it doesn't get fixed, period. Right? And it makes me mad because I think people get wound up in all these gimmicks and they go to physical therapy. Some people, their insurance doesn't cover physical therapy. They have to drive a half hour out, they have to have referrals, they pay a $50 copay. 12 weeks later, they're back in my office sad, right? So you have to be careful. I don't mind physical therapy. It has a place and it has a reason, but it's not for conditions that are cervical or others. So I think, you know, everything has a place. I would not do surgery on a patient that doesn't have symptoms. Right? If I see a prolapse and I don't deem that where it's medically necessary, I don't do surgery. It has a place, right? Physical therapy has a place. I think people want to do all these natural things, and sometimes it's just not the way it is. You can't do enough physical therapy to take a ball and go back inside your body. You cannot Kegel all day long. It's just not humanly feasible possible. So I think this is a good place for me to talk about the package. So when I was a little kid, my brother loved banana taffy. Laffy taffy? Does everybody remember Laffy taffy? Right? You take it out and you're like, oh yeah, right? You bite it and it stretch and you just love it. And then you see like a little part that's hanging, you're like, oh, you bite that on a stretch, and that's prolapse. Okay? So take your taffy. This is where I was going to use prop. I'm so mad at him. All right. Here's the, and I also had a roll of toilet paper and an orange, but we'll have to talk about that later. Okay. So you take your taffy and you pull it, right? Now the two ends are still thick, right? They're still like a square, but the middle is really thin. And if you keep pulling, it gets thinner and thinner and thinner, and that's what happens to prolapse. If I'm a uterus, and I'm going to take away the microphone for a quick second, my hands are the support structures to the uterus, and I'm hanging from the ceiling. Now, I'm taffy, and I start to stretch. I'm strong here and I'm strong up here, but in the middle, it's really thin and weak. Do you really think that doing a Kegel, tightening my muscles is going to help that non-muscle structure? A ligament is a structure that connects one organ to another. It's an attachment, like tendons take our muscles and attach them to bone. That's not going to get repaired. It's not going to get fixed. You have to cut the middle of the taffy, get rid of that thin part, and reattach the other two strong parts together. And that's what we do in surgery. But Kegels are good. Kegels are good for women who have babies, and get out of having a baby, and they have to rehab their pelvic floor. That's the time you want to do physical therapy. Preventatively, to really help women understand their pelvic floor. Kegels and physical therapy are phenomenal for incontinence, although not if you're an adult. And I'm not anti-physical therapy. Again, there's a time and a place for everything. There's a time and a place for surgery, there's a time and a place for physical therapy. And your practitioner has to have a discussion about what your needs are financially, as well as timeline. Remember, you have weekly appointments over 12 weeks for physical therapy. So you have to understand it. It's something I really want to commit to. I could never do something like that. I'm too busy. Then there's pessary and surgery. This is where I live. I live in these two realms. These three, really, my patients I see, those are very seldom treatment options for them. So I live in a pessary and a surgery world. I love pessaries. And I have a nice discussion with all my patients that pessaries are great, but what do you do when you're 90 years old? Because most of us women are going to live really old. We're strong. Sorry, guys. So really, women outlive men. It's just a fact for whatever reason. Though that data is changing as women are more in the workforce though, because of the stress of the heart and heart disease and things like that. But we'll have to see as time goes on. Women are still outliving men. We outlive men, right? We're living longer. You're gonna come to my office every 3 months to have me take this in and out of your vagina. So what does a pessary look like? Sorry, I got ahead of myself. My brain thinks like 20,000 pieces before the mouth. What does a pessary look like? So everybody's played with a frisbee? Yes, right. So you've thrown a frisbee. Now take that frisbee and make it really little. And imagine it's about maybe 2 inches in diameter. And so for the people at home, just take a frisbee and pretend it's like a Barbie or a American Girl doll toy, right? It's a toy. So it's small, it's a couple inches wide, but it's a little tiny saucer, right? And it's flexible to resin. It's non-porous. Why is that important? Because you're putting your vagina into the saline. And it's non-porous because that means that the vaginal discharge that women make is not going to get inside of there and it's not going to cause an infection, right? Are women going to have increased vaginal discharge with the pessary? Yes. Can they have bleeding? Yes. Can it cause incontinence? Yes. And as you elevate that bladder, you're walking around, sometimes the urine comes out. So these are things I tell my patients, the pros and the cons to everything, but it's not surgery. Can you use it? Yes. Most patients will come back to my office, we'll take it out, we'll rinse with a little bit of water, repeat inside, get some of that discharge out, wash the pessary and put it back in. Most of our patients are being anywhere from 1 to 3 months, with the majority being seen every 3 months. The majority of my patients like their pessary. I remind my patients, when you're older and you cannot drive, is this something you're going to want to do? Totally fine. I just like to have us do. I just like to look into the future and help my patients plan their lives, right? So that they're realistic. Some of my patients, I tell them, well, if I had to do your surgery today, it would be very big surgery. But if you get a little bit older and you're not having sex, we might be able to tailor that surgery, make it a little bit smaller. So maybe you want to use this little plastic type of device for a few years. Maybe it's convenient for you. Maybe it's something that you like. Maybe you have a couple of young women who have pessaries and they love it. They're having their period, they don't care to take it out, they wash it, they have sex, it's great. They don't want to have surgery, they're busy, they have young kids, they're working. They might have bad insurance, or even if they have great insurance, they just don't want surgery until they're older. Surgery has its own pros and cons, which we'll talk about. But pessaries are nice. And we just kind of planned. So I have a lady today I saw, she's 67, and she was following on a pessary my nurse practitioner put in, and I was talking to her, but I know I'm seeing you when you're the surgeon. She's like, no, I didn't want surgery. You have to have surgery, it's okay. She's like, oh my God, I'm so happy. And I was like, yeah, this looks like it's working great, and because she knows that she's young enough to need a hysterectomy and some other things with where she's at. And I said, you want to wait another 10 years, when you do a very small surgery, you could probably do a smaller surgery even earlier. I'm just always a little bit careful about that because when you know, they're still young, and they may want to have sex, and sometimes, you know, I close the vagina. So we'll talk about surgery. That's a perfect leeway into that. So you have this bulging, and the patient wants to have surgery, she's uncomfortable. So we can do a hysterectomy. Right? Let's say she has a uterus, and then we do it, right? Then surgery. I'm just like, there we go. Let me put this down. There we go. We have a traditional repair. What is a traditional repair mean? A traditional is, so the first line and the last line are completely opposite. Traditional is that I would say I would be the perfect surgeon to work in a third world country because I need 3 surgical instruments and thread. Seriously, it doesn't take me a lot of effort. And I love vaginal surgery. So traditional repair is that I use threads that dissolve. That is, I'm going to sew you, and 3 months later, you'll never see those threads. The body's going to digest them, and they're going to go away. And I'm going to put your organs in a place, and your body is naturally going to put scar tissue there to holes. Doesn't work for everybody. Remember, it's taffy. If I do a traditional repair and I'm only using threads, they dissolve, then what happens is that taffy has an inherent desire to continue to stretch. So, you know, you put your taffy pieces together and then you pull it, it's not going to stretch. So some people, 15% will fail in traditional repair. Okay. We may do a hysterectomy, meaning we remove the vagina. We may do that robotically. We may do that vaginally. Some people do bikini cuts or the up and down cuts, much less common because most surgeons are now a little bit more advanced in their surgery techniques. I typically will do a robotic reconstruction, and most of my repairs are robotically, except for a few that I do in China. It takes about 4 hours. I always tell my patients, I'm not in a rush, I take my time. And you know, if I'm done in 2 hours, I'm done in 2 hours. If I'm done in 4, I'm done in 4. And my typical operating is 3 to 4 hours for like everything. Hysterectomy, removal of the fallopian tubes because it decreases ovarian cancer risk, expansion of the vagina, thickening of the bladder wall, the rectal wall, opening, and making sure the intestines don't come out. A lot of different departments each take about 20 to 30 minutes, depending. I had one lady whose bladder was very, very large, and it took me almost an hour to do her bladder repair on top of everything else. So every patient is different. Then you have mesh. So again, here's my prop that I didn't. I think of it like pins and holes. Okay, guys, you don't know what pantyhose look like. So pantyhose, you can pick them up, or you can look at these chairs. These chairs, I'm sorry, people all have holes in them, like a lattice, right? Mesh is just like that. Okay, it's like a chain link fence, shrunken down, really small and tighter knit. And the other have those holes is for blood vessels and scar tissue to grow in there like tentacles and pull it and make it part of your own body. As it incorporates that material, it's the same material you make, you fix belly buttons from, okay? Hernia repairs. As you use that material in the vagina, your body will start, and I have now replaced the taffy with mesh. Now your recurrence rates are much different, right? So in a traditional repair, I did nothing. I used your own tissue. It's all the same stuff. Nothing has changed. Now I've given you support. I have given you better material that God did not give you or that you lost during your life. And this material will grow, and it won't grow, but your body will grow into it and incorporate it, and your success will be 98%. Mesh has its own inherent complications and risks. Okay, he was in 2011. FDA banned a whole bunch of mesh products. Why? Because a bunch of people who were not adequately trained, who were told, unfortunately, that because you're a gynae and you do vaginal surgery, you should be able to put this in and it will be great, right? So they went to a few courses, they did a few cadaver courses, these surgeons, they learned a few things. And then they went and made the surgery on a few patients, and the product was correct. It had a lot of erosions, it started coming out of women's bodies, they didn't have sex without the male penis, the only distraction was on them. So I spent my fellowship taking out a lot of mesh, okay? Good, bad, and different. A lot of those products by the FDA luckily came off the market, The doctors who didn't have fellowship trained, like I have 3 years where I just did this surgery, nothing more. So those doctors who didn't have my type of training stopped doing those surgeries. They realized, wait a second, this isn't as easy as it works, even though I can do surgery. Doesn't mean that this product or this technique is great, right? So we started understanding more about mesh. We started learning the pore size, like the difference between maybe this size hole and maybe a bigger size hole, and what size opening in the mesh is the best mesh to put in people's bodies, right? So you want to look at rejection, you want to look at how it incorporates, you want to look at elasticity. The vagina is a dynamic organ, right? It's not like a plastic model, right? You want to have walls that expand, and the bladder expands, as right to fill with urine and then empty. You have to have a rectal wall that fills with poop and then can extract the poop as you have bowel movement. You want to have a vagina that can stretch and the penis goes inside and the penis goes out, right? That's a plastic model. You can't do any of those things comfortably. It's too stiff. Some mesh products made it too plastic. So the mesh that we use now is much different. It's much safer. It's all FDA approved. And the way we place it in, I mean, it was a couple years ago, we don't place it in vaginally anymore. We place it in abdominally. So most of the surgeons will place it in abdominally. And most surgeons, not all, because every patient is different and every surgeon is different. You know, some people, all they do is mesh, and that's their best thing that they do. Some people do a variety. I'm more of a variety, and I choose my patient for what I want. I use a lot of different tools. A lot of surgeons will do a traditional repair, and if the traditional repair fails, which is a 15%, they'll use mesh. Some people fail mesh, there's a 2% failure with mesh, so sometimes that happens, and then you know, chronic pain. I don't like to use mesh as a primary surgery unless my patient is very young and very active, and we have a whole discussion. Because it has its risks, you know, risks with chronic pain with intercourse. Once I put it in, you own it. And I tell that to my patients, I can't put in mesh and have you expect that, oh, I don't like it, let's undo it. You know, surgery is a one and done. You know, you operate, we change things, you have to be really sure. That's why I like the pessary. Try the pessary. I always tell my patients, try the pessary. You don't like it, and take it out and hand it to me, done. Right? You're back to being however you were before. Surgery, once we do something, we can't undo that. And I've seen a lot of patients with surgeries that, you know, are good or bad, right? Can't undo that. Very difficult. So it's a polypropylene. Thank you. Yeah, this is very delicate. It's a polypropylene. I always tell my patients, I have a mesh product in my office. And I show them, I'm like, if I take a lighter to this, it will melt. It is a synthetic, it is a plastic. It is graded to be placed in the human body. So it comes in a sterile packaging with an expiration date. There's a couple of companies that most physicians will use. One of them is Boston Scientific, another one is Prolapse, and another one is Johnson & Johnson. Those are the three big players. And people use a variety of different things. Some people still do vaginal mesh. It's not FDA approved, and they're, you know, for synthetics. There's two types of mesh: synthetic, meaning it's plastic, and then there's biological, which come from cadavers. Sometimes people take fascia, which are tissues that are supported when your own body will transplant it. Some people use porcine or pig graft tissue. I don't use any of those. I find that my traditional repairs for vaginal work just fine, and that's just my own experience, you know, and I see my patients out for a whole year, and I'm pretty comfortable about putting mesh in. Again, because once I put it in, you own it, right? If I give you threats that dissolve and go away, okay, maybe you're back to the way you used to be, but you're not back to where I can't undo you, right? So I'm always very conservative with what I do with my patients, whether it's a pessary or a traditional repair. Can you go to the next slide? Thank you. Prevention, people. You know, like I said, your mom finishes having a baby, teach her how to do Kegels, teach her what her pelvic floor is like, teach her how to get constipated. You know why women are constipated? Because we're too busy to sit on the toilet and have a bowel movement. Okay, I came home, my kids are 11 and 8. Yes, 11 and 8, and a 2-year-old daughter, my nanny, who's my cousin. This is all too much information. I come home about a month ago. I'm running in the door, and you see I'm still in my work clothes, right? Because, you know, I work a lot. I come home, I'm like, okay, guys, I gotta go pee. You know, like, just hold the barrage of like, you know, me. So I go, I run in, and my daughter comes in. Okay, she's 8, she's cute, right? And the dog comes in after her. I'm like, okay, there's Kegels jumping on my knee. I'm like, okay. And then my nanny, who's my cousin I grew up with, we're like twins, she's 38 older, and second house with caveat. She comes in to talk about what the kids do. Someone's 11 standing at the door, trying to talk over everybody else. I'm like, you got to be kidding. I need to smirk on people out of my bathroom. But that's a mom's life. We never can go to the bathroom without being bothered. So you're gonna get up, you're gonna sit down, you're gonna be like, oh my God, I gotta make breakfast, I gotta get the kids ready for school, did they get their backpack? Oh my God, I didn't finish that project. Did they put this in? Did they brush their teeth? So you get up, you sit down, you barely have time to pee. You're like, I poo, you push, which you shouldn't be doing. Oh, it doesn't come out, you jump up, you're like, I'll poop later. Later becomes tomorrow becomes the day after, and then what? Once a week, twice a week, you're pooping? Yeah, because everybody follows you in the bathroom. How can you poop when everybody's watching you? I'm like, does anybody here have privacy? I'm like, do I go into anybody's bathroom? No. In fact, I'm like, thank God I'm in the bathroom. I get a little reprieve, right? So constipation is really important, you know, and doing Kegels and pelvic floor and toilet training is important. Taking care of yourself and putting yourself first is really important. You know, I said it earlier, women think they can do everything better and faster than men. Some things you just shouldn't do. You shouldn't move furniture. You shouldn't do chronic heavy lifting. You just shouldn't. It's bad for your pelvic floor unless you do it correctly. So you should avoid heavy lifting, avoid the Valsalva. The Valsalva, sorry, it's not good tomorrow, when we go poop. We are going to try to poop without holding your breath. Furlong is right. I hold my breath and I bear it down. That's the movement that causes prolapse. That's the movement that delivers a baby. That's the movement that gets you to move a mattress to get the fitted sheet, to pick up the case of water from the Costco. You're holding your breath, you're lifting, you're pushing, you're moving. That's what causes prolapse. So, you know, pelvic floor physical therapy, important early on, before you have problems, not when you have a problem. Because once the taffy is stretched, you cannot unstretch the taffy. So learn how to take care of your pelvic floor early on. And next slide. Constipation. I talk a lot about constipation because I don't think people understand enough about how it impacts a woman. First of all, you have to have, so my patient today who's 39 years old, we talked about, she has constipation, and I talked to her about, you know, what are your toilet habits? She's like, you know, I've been getting up an hour earlier now when my kids are not asleep, to sit down on the toilet for 10 minutes a day and get a regimen where I'm gonna sit down and I'm gonna just wait. Guys, you know why they do? They do the paper, they shut the door, they play their video game, you know, they're like, oh, this is my bro. What are you doing? I'm pooping. Nobody wants to go in, you know, we don't want to open that door. Right, so guys, you know, they have it all figured out. Women, we don't have it figured out. The dog, the kids, the man, everybody comes in. So constipation, 24 grams of fiber. Go home and add up how much fiber you're having. The average American diet has 11 to 12 grams of fiber a day. We're less than 80%. There's soluble fiber and insoluble fiber. Soluble means it's like the oatmeal. You put it in water, it dissolves and you don't see it. Insoluble is like a carrot or a celery. You know, you try to mix in water and you still see it, right? It's rough. You need both, okay? You need a combination. So then people are, everybody's gonna go out, they're gonna buy their bottle of Metamucil and home, they're gonna scoop it all into their thing, and the directions are 3 times a day. You guys are all gonna go home and do it, right? And then you're gonna blow it and gassy, and you're still gonna be constipated. Fiber doesn't work that way. Okay, you're gonna supplement with fiber slow and steady. It might take you a month to get to the doses you need. So if you have to supplement, let's say 10 or 11 grams of fiber a day because your diet is a typical American diet where we don't really have complex carbohydrates and we're really not eating roughage, and you're supplementing with something like Benefiber, Metamucil, psyllium, all the different things. I'm not a fan of pills. I'm a fan of things that mix in the water when you're talking about fiber. And so you're going to want to start off with a teaspoon for 3 days, then a tablespoon for 3 days, And then if you're doing well with that, and you don't have bloating and you don't have gas and you're not on the pump, you're starting to see slowly. There's no race, okay? Other things you can do for, there's totally setting up. Miralax, I'd like to take Miralax forever, but you gotta be careful that you're not, not see your GI, because you want to make sure you don't have colon cancer, right? Because as we get older, all sorts of things happen. So make sure you're up to date on your colonoscopy and you clear with the GI and there's not a problem. But typical constipation has to do with diet and exercise and hydration. If patients are leaking on themselves and peeing all night, they're not drinking water, right? So there's a lot of different things that go on with constipation. So when they're not drinking water, and then they're getting constipated, and then they're bearing down, and they push out their uterus and their vagina, right? And so it's just the downward progression. So this is all about the prevention, right? The Kegels and the physical therapy are perfect after childbirth or as a young woman is younger. I've been talking about this when we talk about Kegels. I know some women are like, I don't know how to do a Kegel. So I was telling them, you can do a Kegel by holding in your gas. Okay? And some women can't do that. But my favorite little story, you're in line, right? And there's this really cute guy behind you and you have to pass gas. I guarantee you, your pelvic floor muscles take right in. You're like, oh yeah, no, you guys hanging can't do that, right? So you have to remember your pelvic floor muscles help with just more than just the vagina. They help with the passage of a lot of things, and we can use them. So many patients are like, sorry, Dr. Furlong, I still don't know how to Kegel. Fine, go to the bathroom and try to see if you can stop your urine stream. Everybody's always sat in the bathroom like, is that the phone that rang? We're older now, we have our cell phones. Now we have our cell phones, we're going to stop the urine. But let's make someone call, you want to talk to them, you stop your urine. Some patients can't do that, but that's a poor man's way of learning to Kegel, because you don't have poor physical therapy. So try to learn to stop your urine stream. Now, I'm going to be right on the tail of that thought. Do not do that long term. It is bad for your bladder. I don't mind if you want to learn where your pelvic floor muscles are, if you want to see how strong they are, but you can't do it forever because you'll have incomplete bladder empty. But it's a good way to say, okay, today I'm Kegeling and my urine stream just kind of slowed down and dribbled. Tomorrow I Kegel and it just stops like that, right? So you know if you have a good Kegel strength or not. And then you want to Kegel outside of the bathroom. So I have patients who are like, Dr. Furlong, I've been doing Kegels all month and I'm still leaking urine. A lot of my patients do it for incontinence. And I tell them, yes. Do you do your Kegels in the morning? They're like, yeah. I'm like, that's great. Do you do your Kegel when you sneeze or cough? They're like, I never really thought about that. I'm like, well, your Kegel only works during the activity of what makes you weak. So when you're coughing, you Kegel. You can practice them like an exercise, but you actually have to physically Kegel when you cough, sneeze, laugh, so that you don't leak urine. And then of course, you just always Kegel for pelvic floor strength. Blood flow helps all the pelvics. Next slide. Oh, it's missing the slide. Is that you? Mm-hmm. Go back over. That's the end of constipation, right? Okay, so let's see, what else did I want to talk about? Go back a slide. Let me make sure I covered everything. You don't have to look at constipation. Go back another slide. Surgery. Surgical repairs, sometimes I have very older patients. In fact, my oldest patient that I operated on was 92 years old. And when I did her surgery, what I did was I closed her vagina. She's unable to have intercourse. So I can make a designer vagina, right? We can make them normal to have intercourse. We can make them medium. I can make them where they don't exist. The reason we make them where they don't exist, and so a patient will put her feet up, she has the lips or the labia, the clitoris, the urethra, and it looks like she has an opening, but if you put your finger in, it only goes in maybe to the first knuckle and it's only 1 or 2 finger breadths wide. Why? Because that's almost 100% success rate for surgical repair of prolapse. Patient who's not having intercourse, who hasn't had a partner, who doesn't want to have intercourse, has a lot of, our younger generation is much different than our older generation. Now remember, the newer generations, they have internet, they have different values, they have different thoughts. My older generation tends to be a little bit more traditional, a little bit less savvy about their vagina, sex, and multiple partners or having partners. And again, as we get older, a lot of men our partner availability. We saw a lot of women are not having it. First, we close their vagina. It's a small surgery. I don't enter into their abdomen. The risks and complications are very low. My patients are super happy. You know, this is a great quality of life. I'm not changing a pessary every 3 months. I remember I was in Florida one day, and a bunch of male surgeons were with me. We talked about that, came up on the slide of the presenter. And I was like, oh, you know, we were all talking in the group we were all talking in the group afterwards, and I said, I do colpectomies all the time. You know, my patients love it. It's a great satisfaction. I've got 80-year-olds, 85-year-olds, 90-year-olds, you know, some women are in wheelchairs, some women are in walkers, you know, some women have, you know, they're living in assisted living. So it's a great surgery for them, and all the men moms drop. And they all said, I've never done one of those. And I was like, well, things are done. So it's interesting, like the surgeon perspective, right? So here's a minimally invasive, very small surgery, and they're using mesh and reconstruction. And this one surgeon was like, that is just criminal. You have to do that with women, and you should always leave the option. And I thought, a 90-year-old is really not thinking about having sex. You know, she doesn't even have a partner. You know, some of her kids aren't even living anymore, right? So I think that, you know, an informed consent from a patient and the understanding that it's not reversible is a very safe and humane option. And I'm surprised that it's not even offered in some parts of the country because people's perspectives are biased. I don't tell my patient what surgery to have. I tell my patients the surgeries that are available. Now, my 90-year-old lady, am I going to do a robot and put in mesh in her? No, never. I just won't. It's not going to happen. It's too much surgery for a 90-year-old. She needs to find a different surgeon. I ethically cannot do it, you know, because it's just too much. I think a traditional repair with a lot less risk and a lot less time in the operating room is appropriate. But there are people who do it and they find it appropriate. That's okay. Everybody has a different option. But in a 90-year-old, I won't do it. I also won't close a 40-year-old's vagina because she's not having sex anymore, you know, and decide that, or a 50-year-old. They're just too young. So I do use some of my own bias. I would imagine just like those gentlemen had their own bias on what they chose. But I try to be more of a person who looks into the future of my patient and an advocate for what I think is important for their life. Do I want my patient under the operating room for 4 hours under general anesthesia? Yes.
I just had a question. A friend of mine, she was saying that she's 70, but anyway, I think she had uterine cancer. She's cancer free now, but when they did the hysterectomy, they said they have to leave it now.
Yes.
And I had other people that I never heard them say they would get hysterectomy.
So, and congratulations on her surviving cancer. A vagina is always left in cancer. And the reason is because the oncologist wants to always put their hands inside the vagina and evaluate the pelvis for recurrence. So when I close my patient's vaginas and my patient ends up with a cancer later, there's a conversation we have to have. My oncologist hates me because it's very hard surgery. It happened to me once, but she didn't actually have cancer, but she had some abnormality. He went back and did surgery. He said, wow, that was a really cool surgery because the vagina was closed. I couldn't my landmarks. And I was like, well, you know, but it ended up not to be cancer. Regardless, you know, there are pros and cons to everything. You know, I always let my patient know if your ovaries are in there and your uterus is in there and I'm closing your vagina, the risk of cancer in an organ is always undetected. I'm going in, right? I don't take out someone's appendix just because it's there, right? I don't take out a gallbladder just because it's there. I don't take out the ovaries just because they're there in the menopause. Right, there's pros and cons to everything we do, and it just requires a long conversation. And I will say, I try never, I never say I'm 100%, but I try not to consent my patients for surgery without having a family member or a friend or a bestie or a neighbor or somebody there to be an extra set of ears, especially as my patients get older. Because sometimes they're kind of like blindsided by all the information I need to give them, and I tend to talk a little bit fast. Try to slow it down, but sometimes it's overwhelming. You're anxious, you're nervous, you're thinking about one thing and the doctor's saying something else. So it's always nice to have an extra set of ears. I'm not always perfect about it, but I try. And so we always don't need to remove the uterus. I try to remove it because people I think are going to be high risk for cancer. And sometimes my patients, they don't know why I do that. They give me the least amount of surgery. I had this one lady, very, very nice. Her name comes right to my mind. And she said, Dr. Furlong, don't take out my uterus, my ovaries, or anything that's closed. She's like, I can't believe that. But the other doctor I went to wanted to do a full reconstruction. She's like, I love it. This is a great option. I'm going to take it. You're young. What if you get cancer with uterus? We did a biopsy, we did an ultrasound. Well, the organs are good today, but in 5 years, I don't. She's like, I have no family. I have no husband. I have no kids. I have no one to ever take care of me. I'm going to go back home. My neighbor's going to drop me off and pick me up. She's like, I need to be able to take care of myself. She said, just do the least amount of surgery. And I said, well, that's a good decision for today, but in 5 years, is that a good decision? She said, yes. Because I'm older and I think my risk is really low. And I said, well, that's fine. We can also do a CAT scan or MRI later on. I'm whatever my patients want. I have some volume. Let's do ultrasound. Because I always think, well, if I was the president of the United States and I had a little, twinge in my heart, would they do it? And I go, probably. Is it a misuse of medical funds? I don't think so. I have a lot of patients who come to me. I have a lot of patients that come to me, and I have a list longer than my arm who are like, Dr. Furlong, I know something's wrong. I said, well, I believe you. I had a lady, she came from a gynecologist. She's like, I'm leaking urine. And I'm like, what was it? Yeah, it was urine. She's like, she said, I'm leaking urine from the vagina. I said, okay. I believe you. She's like, but my other doctor never found it. I said, okay. So I was seeing her. I looked inside the bladder, I didn't see a fistula, that's when one organ communicates with the other. I said, fine, I'll send you to the hospital, to a CT urogram, a retrograde, no fistula. I said, we don't have a fistula. So she left, she came back 6 or 7 months later, she's like, I'm telling you, it's coming out of my vagina. Now everybody has done a pelvic scan, even me, 7 months ago. Put in the instrument, opened up, I looked around, getting urine in there, swallow that well. And I don't know what made me think that, but I believe this lady. I said, great, let's bring you back, let's look at your bladder one more time. She said, thank you. I said, I believe you. You think if that's what happens to you, it's not my body, it's your body. The one that you wake up, you know what's going on over there and what you feel with cramps, right? I took the camera and I put it in her vagina instead of the bladder. After I looked in the bladder, I'm like, maybe I'm not seeing something. So it's called a vaginoscopy, and sometimes you do that. So I put the camera in her bladder and I looked around, sure enough, I found a hole right next to her cervix. And I saw something coming out of the camera. I'm like, I found it. And she's like, you found it. I'm like, it's not urine. It's white cheesy stuff. I'm like, yeah, so yeah, it's here. So we took it out. We did an MRI. She had cancer outside of your pelvis that made a hole into her bladder. Now, why didn't see that when we did her CT urogram 7 months ago? Because they were only looking at the urinary tract where the dye was. So when we did something that paid, we found it. Sure enough, not there and anything. Why? Because I believe it. So, I think, we order extra imaging. My gynecologist that I refer all my patients to, like, Dr. Furlong, do you have a sign that says come here? I said, well, if you don't look, you don't find. My patients are about 20 years old. Things are happening. You have to listen to people. You have to take that extra step. And so, for me, I'm okay with doing that. That's just how I practice. And my patients prefer their contained therapy. Yeah.
About November, I had 10 UTIs. I like my urologist. He doesn't like using antibiotics, but he gave me one that worked before. But and then the last time he gave me some, it was the worst. And when the urine would leak, it would sometimes go down the side. I'm not that far from the bathroom, but I could go Kegels all the way down. But it's only like on one side. I did all the little tests with the bladder and the pelvic and all that. Everything looks okay. Well, I don't know why. Okay, but I just, it's just frustrating. But anyway, I went to one of the OSF, care places. I actually had a fever. But anyways, and whatever they gave me this clear X or whatever it's called for 10 days. what kind of went, but I've had a couple here and there. I find when I get older, nervous maybe, but I mean, this has been since November.
And you never had infections before?
Oh, I think a few I don't know, he hasn't been touched, but when his nurse first did the little thing, she said, "Here's some bottles and things, your bladder, oh." And then after again, so my liver guy, he goes, "Oh, there's no problem." And I usually have a problem with that occasionally. But I think a good point about making people sit, on the toilet. My dad was reading like, but I'm saying, 10 minutes.
Sure.
Be, and don't just try to hurry, I sit there about 5 minutes. But I'm just saying, it's so annoying that everything's fine, well, no, it's not fine, I'll find something else in there. And there might be causing kind of one over that. Sometimes they say they can't see it, like 100% there. Here's why you can't see it in the screen. And it's spread, I'm like, how many years ago was that?
So the question is recurrent urinary tract infections over the last few months. And my first thing is, what's your pattern in life? Is this something that happened right away? Or did you used to have 5 infections and now you have 10? Your urologist doesn't like giving antibiotics and you're in pain. Sometimes you need them. I understand that when I know there's a big philosophy of lead infections in women. I don't know about the male population, I don't think their literature, but you can leave infections in a woman, she will eventually develop an insensitivity to the discomfort of having an infection. But like you said, sometimes infections cause incontinence, right? So then you're wetting your bed, you're wetting your clothes, you have to be close to a bathroom all the time. When I have my patients for recurrent urinary tract infections, my basic workup is a kidney ultrasound and a pelvic ultrasound. So I always make sure that there's not a tumor or something that's pushing on someone's bladder. So people are like, but it's a urinary tract infection. What do you care about the uterus or ovary? Well, I do. The tumors push up on stuff. And like my other patient had a tumor, right? And so we look in the bladder with the camera, which is called a cystoscopy. We make sure there's no stone. Sometimes we can do a post-void residual, meaning did you empty out your bladder completely? Because sometimes having a little bit of retention is kind of like pond water, it just continues to fester and grow bacteria. So you make sure you're empty completely. A normal bladder will always have 3 to 4 ounces after a pee. So any woman can sit down, relax and pee, stand up and push and get more out. That is normal. You're not supposed to push to pee. But some of my patients have recurrent urinary tract infections feel like they really have to empty. Literature shows you have to drink almost a gallon a day to really flush out an infection. Because it's got to be like a river where you just really clean out. That's
Like
yeah. Some people do denano, so the study last year that showed that that's effective. Some people like cranberry pills. The bacteria tend to, I think of rock climbers, you throw the spike and climb them up, and that's what bacteria do. They kind of work their way from the anus past the vagina and slippery slide up into the bladder. I like a mainstay of estrogen creams because it increases the ability for the bladder to stay closed. Even sometimes in my younger patients who might be on a birth control pill or have a Moran IUD, sometimes a little supplementation will help them because it helps keep the integrity of the opening closed tighter, helps with moisture. So a lot of studies show that prevention of the UTI can be done by twice the estrogen cream. Even if you have a history of breast cancer or ovarian cancer, it can be very safe. And that's a discussion with your physician on the pros and cons to that. I've also, my patient really has 10 urinary tract infections and they're uncomfortable and they're symptomatic and they're getting fevers and it's going up to their kidney. Rather than going into the ICU and getting urosepsis, I'll put them on 6 months of antibiotic suppression. As we get older, our symptoms of a urinary tract infection are different. When you're younger, it's urgency, pain, sometimes bleeding, discomfort, right? I don't feel like I am CLP. I feel like it's still something there, sharp things are coming out. When you're older, when I first started in neuroscience, my patients are like, I know I have a UTI, Dr. Furlong. I'm like, oh, okay, well, what are your symptoms? My fingers tingle. I'm like, looking through the book, I'm like, yeah, okay, I'm gonna write that down. Got it, sure. Next patient. Dr. Furlong, I know I have a UTI, test my urine. Oh, really? What? My fingers tingle. And I know that's not in the textbook, you know, Mary Jane just told me that. And then she told me that, and she told me, now I ask my patients, your fingers heal up before you come to their life. Because I've had enough people tell me these things. And so after a while, you're like, well, it must be like a symptom. And people have all, you know, I get the chills. I know I have an infection when I feel a little, you know, unstable or woozy. And as we get older, urinary tract symptoms are very different than when we're younger. So you have to be really keen with that. And I'm all about sending urines to the laboratory and getting cultures and seeing if they're getting resistant and, you know, if, and know what is it growing? Is it, you know, MRSA or, you know, PBL, PSBL. I had a lady last week. I saw her for, we did a procedure on her. And, it was about a few months she was seen us, and I was going over her history. One of my colleagues saw her. And it says sudden onset of urinary incontinence. I'm like, whoa, wait a second. I don't like anything that changes from one day to the next. If I get up and all of a sudden my life is different, something happened. I need to find out what it is. If it's gradual, it's very different. But I told her, it was six months ago, you woke up and you started having this symptom. She's like, yep. I'm like, you've never had it before. She's like, nope. I'm like, okay, you need to look in your bladder. I'm like, you might have something that's blocking, or you might have something. She's like, oh, okay. I'm like, you know, of course I'm looking for cancer. And we talked about it, and I brought her back, and I looked at her bladder, and I couldn't, the scope didn't see anything. And I'm like, over my scope, I took my scope out of the bed, and I think it's working. I put it back in, I can't see anything. It was like, oh, and it's really weird. So I take it apart, and I look through the ocular, and I still can't see anything. I'm like, so weird. So I took the camera out. I'm like, oh, we cataracts, or what are we missing? So I started to drain her urine. I thought maybe she had a ton of urine and maybe, you know, the color was different. Sure enough, I'm like, oh, you have a really bad urinary tract infection, but the infection was so bad, the culture didn't come back correctly. Came back contaminated, and we took the color, you know, white, and then give us another sample. And it was with pure pus coming out. I'm like, okay, I got you. I'm gonna fix her incontinence. Let's do some antibiotics. You know, so everybody presents differently, and you know, our infections always treated. Sometimes they are, and you know, I don't know your whole history, so it's hard to say if each infection should be treated, or whether or not you do suppression. I mean, there's a lot of things that factor into that. Resistance, allergy, just you know, comorbidities of kidney function, right? You know, you're uncontrolled diabetic, or you know, a diabetic, and things like that. So you know, really takes a lot more than just saying the physics. It is.
Everything's fine, you know.
Yeah.
Like, you get over here and so then I go, okay, please tell me when to get it out of there, and I'm like, yeah,
Well, like I said, you can have up to 3 ounces and it's normal. So it's all about, you know, getting up and you know, toileting every hour and drinking a ton of water. As you get older, you have to be careful with simple water because it can decrease your electrolytes like the potassium, the sodium, and you can get dizzy. So I tell my patients to get potato chips with it. That's a nice inexpensive way to buy Gatorade. Or you can do noon tablets, NUN are still my favorite. You keep them in your purse, throw them in the water, they dissolve the effervescent. You can do juice and then water. You can alternate so that you get like a variety.
I had to do the solid things in the bed, you know, years I had training of showing how to do all the pelvic things, but the right pelvic bone seems to protruded, and they look, and they said something.
Any other questions? Anything else you can find to know about the pelvic floor? Yes.
You ever use Botox injection?
Incontinence is always such a hot topic. We were just talking about that. Yes, I love Botox. In my eyes, I think Botox should be a first-line therapy for all women who have it for incontinence. The problem is insurance doesn't cover it as a first line. You can fail 1 or 2 medications depending on your insurance. If you fail your medicine, you go to the pharmacy, you need to pick up that medicine, and whether you throw that bottle out, no, I shouldn't be putting out on video. FDA's gonna come and get me. Whether you take that bottle and throw it in the garbage, I don't care. You just need to come back and tell me it didn't work. Or if you take it and you like it, then you like it, and you can be refilled. But side effects of all the pills and medication are dry mouth and constipation to varying degrees. The more expensive the medicine is, the less side effects. The cheaper one that your insurance will pay for, the worse side effects. Prevention is a good one, but can increase blood pressure to be $350 a month. very inexpensive and cost prohibitive for my patients. The United States just asked me to do a study on overactive bladder, and I think it was, it's for veterans new competition. It's not covered by Medicare. And during this survey I was doing, I paid like $20 a year on medicine. And as I'm doing it, they're like, well, what percentage of Medicare patients do you have? I'm like 80%. They're like, you don't qualify for the study. I'm like, of course I don't. Because Medicare doesn't cover the good stuff. So why would you want my opinion? And no, my patients can't afford to have that. So I kind of did that myself, or them, I should say. But it's interesting, medicine's a business, right? And pharmaceuticals are a very big business. So, because insurance companies don't put Botox in the first line is really unfortunate for my patients. A lot of them will benefit. We do the injection. I did one this morning. I love my patient. She's really cute. It comes in every 3 months, and finding out my processes right. My office, turnover from COVID, and so she's really cute. She's like, oh, you saw me at 3 months. And yes, I got you in. I bought the medicine. We're all set. It's a big to-do thing. There's some frequently and showing these guys and showing this schedule. She's always something. So I've been doing her Botox forever. So such a happy person. Do it every 3 months. It starts to wear off. We talk about some other options. It's not perfect, but it's nice. It works at 70%. The side effects are very uncommon. It can be some inconvenience, but it goes away. You won't have to dry mouth, you won't have constipation, you won't have enough pot, right? And I do it in my office, and it's fast, and we save some for our legal, but I always wanted to. As I'm continuing, I'm like, wow. Then I look at my patient, I'm like, she needs more. I'll let my wrinkles just kind of fester for a while, But so I like Botox. There's also, if we talk about condoms very briefly, there's also the battery implant stimulator that goes in the butt cheek that works for 5 years. Don't put that as much. Maybe because a lot of my patients, insurance is, it's a lot of out of pocket to go to the hospital and the operating room. It's a lot more to do. I think they tend to find that the Botox and, turn around just as good and they come in. Some women, it frequently come in every 3 months. And I just use her as an example. I have a lot of patients coming annual for their Botox on their bladder. And I'm like, God, please call me, 4 to 6 weeks before you need your Botox. Don't tell me when you're leaking. It takes me, I had to do this insurance coverage with a pain. You got to go through Botox 1, you got to get prior auths, you got to, and sometimes I don't have staff with COVID, people are out. So, they're really nice patients. So I just remind them, like, I'm just a phone. I put them up on the phone. Yeah. Botox is about $1,000 for the vial and a few $100 for the procedure. And so that won't last more than a year. So my true overactive bladder patients who are a little bit older, my younger patients can get stretched out 8 months to a year. A lot of my older patients are really at 6 months. I find 6 months in most of my older patients. But it's a nice procedure. It takes 5 minutes in the office. It's easy, it's fast, it works well. So when I put it in, there are 10 injections. When I put it in, it takes 2 weeks to get to where it wants to be. So I tell my patients, don't walk out of the office and think you're cured. They're like, okay, it takes 2 weeks, okay? And then people call the office and no one told you 2 weeks, but they still call. And so they start getting into the habit of understanding it takes 2 weeks. And then it hits its peak and it stays there. And then it'll start to wear off. That's why last year when I did my Botox, it doesn't work anymore. I thought there's different Botox all the time. Then when I yell at my kids, it looks like I'm happy. Right? That's right. They're like, Mom's so mean. Look. I love something foul at you. As you're in my bathroom, can't even pee, let alone. I'm scared like a food spray. And one of those, yeah, and I think that'll clear them out of my bathroom. But yeah, I love Botox. There's also another one that's called percutaneous nerve stimulation. I like it, but it's a little bit to do. Medicare will cover, I think, like 2 years of treatment, which is every week or less. I don't do it because I find it inconvenient for my patients. There's a little needle that goes here and you, and it's a tibial nerve and you stimulate it with electricity, kind of like a TENS unit or acupuncture. They come in every week, they do a 15-minute session, and after 6 weeks, if it works, then you do 6 more weeks. Yeah, 12 weeks. So I'm like, okay, let's have you committed to coming in every week, you know, and getting this procedure done. And if it doesn't work, you just, you know, use your time. And I find the efficacy of it's not so high, so it's not my favorite. And after 2 years, it's not covered anymore. So you maximize out on benefits to that. So it took too much for me to kind of really offer aggressively to my patients. And then remember, you need a pelvic exam. You know, there's something pushing on your bladder. Is your uterus okay? You know, you have postmenopausal, you know, your urinary tract infection, really on something else, right? You know, do you have urinary tract infection that's causing your incontinence, right? Or do you have prolapse and that's what's causing your incontinence? You know, is your bladder really bulging? You're not. You need a good exam. You need someone to take a look. I had a patient today. I always have like tons of stories. She had seen 2 previous physicians and she didn't see me. Like, no, I've heard. Couldn't pass that. But after I got past that, we ended up talking. She said one of her doctors walked in after the resident, and the resident told her to get dressed. And then the doctor was like, oh, you don't have problems. She's like, you didn't examine me. The resident examined me. She's like, oh, my resident told me you don't have problems. She's like, I'm telling you, I have problems. She's a healthcare provider. So then she finally came to see me and she has problems. So, you know, you just have to have a good exam. You have somebody who takes their time and listens to what the complaints are. You know, and if you don't get the right answer, whether it's from me or someone else, there's nothing wrong with collaborating. There are times where I call other doctors and I'm like, hey, what do you think of this case? I call them and say, of course. But you know, what do you think of this man's? You know, it's kind of borderline. I'm thinking this, and you know, we collaborate. That's what we do, right? Nobody's perfect. We all have to kind of understand where our boundaries are and how best to treat the patient. That's why we have surgical options. That's why we have conservative treatments, right? And so it's just really a discussion about what's important to you as an individual, right? And what are you seeking? What are you doing? What are you doing? And what are your goals, right? Where do you want to be? Some patients, I have patients take off diapers, and I'm like, you want some medicine for that? They're like, yeah, we can do that. What about you? Oh, sorry. Everybody's different, right? Everybody is different. We cannot enforce or project our values and our goals and our desires on other people. So I always ask, what bothers you? I see some problems sometimes, but bother you? No, okay, duly noted. If you ever have A, B, C, or D, this is what it is, and this is how you fix it, and this is where you go. Thank you. That's it. Any other questions? Yes. You can buy them on eBay. I think you can buy them on Amazon. I'm sure you can buy them online because I have patients buy a lot of stuff online. The problem is you don't know what size to put in your vagina. So that's really the problem. Like you get a 2, you get a 4, you get a yellow horn, you get a ring, you get a gay rum, right? You get a Q. So size and shape matter. And the dynamics of a pelvic floor matter. Because, you know, remember I told you guys the opening of the vagina is a circle. And if it's this side, and you have a bowling ball sitting on it, and it stretches to that side, I need to put in a pestle that's bigger than the opening of the vagina, it's going to fall right out. So the diameter of the opening of the vagina called the introitus is important. So I have a lot of patients who are like, oh, I have a pestle that keeps falling out. Well, that's because the opening of your vagina is too big. So yeah, if you go in your vagina, then it falls out of your vagina, and you get up and walk across the room, you go to pee, or you sit down and start pushing, right? So if you go home, they're going to push. So yeah, you can put it in yourself. So what I like to tell my patients, if you're able-bodied, no matter what your age is, if you can take your 2 fingers and pinch them together, put your leg up on the toilet stool, and put your hands inside your vagina, you can take your petri in and out yourself. There are some shapes that have some suction device to it. You know, sometimes when they do fall out, the opening's a little bit bigger, but not immensely bigger, right? And so it can hold something that has a little bit of suction. Those are hard for patients to get out, because you have to pull the knob, and then you gotta kind of get behind it, and you gotta kind of twist and pull it out. Leave your feet kind of going in, harder, you're going around your own body. But it can be done. I have a lot of young patients. My young patients, they come in, they take it out when they have their period, they take it out when they want to have sex. Some leave it in when they have sex. I have comments about that, but I say that in the exam room. So, but yeah, some leave it in when they have intercourse, and it's not a problem. Their partner never knows. So it's interesting. You know, and sometimes the pessaries cause ulcers. Like I said, if I rub my elbow all day long against the wall, it's gonna have a sore. The pessaries in the vagina, you're walking, your pelvic floor muscles, they move, sometimes how much you swagger down the hall. My daughter's 8. My mom's like, who's her walk like that? I'm like, she's born that way. She just swag. She's got a big booty. She's so cute. And I'm like, oh, Annabelle, you're so cute. She's like, yeah, that's because her thighs are big, so she kind of keeps her moving out. She's so adorable. But you know, certain people move certain ways, right? So their pelvic floor moves, and as it moves, those muscles move, you have something there, it's gonna roll constantly. You're gonna get a bruise. That bruise may bleed. So I tell my patients that happens. It's great if you can take out your pessary at home. The more you take it out, the more that there's less contact it has with the vaginal wall, the less ulcers and discharge and death. I have a very best friend, she used the pessary, the bathroom top when I met her. So I met my first meeting with her, very funny. She's like, oh my God, you're a gynecologist. And I never got out of the bathroom, ever. It was about 2 hours later, somebody came into the bathroom to find me, my husband was looking for me. I'm like, yeah, we're having bathroom talk. It's like, I'm just, you know, and then, you know, one person would leave and the other person came out of the song like, I heard what you were saying. I've been waiting. I wanted to ask you. I got cornered. It was funny. So I'm like really popular in the bathroom and in parties. And men, after they have a few, you know, they really loosen up and, you know, they're like, all right, I have some questions for you. Your wife should be present. Or your significant other. Yeah. But yes, you can take your pessary in and out yourself. It's easy to manage. It depends on the pessary. It's very hard to fit yourself with a pessary. I suggest that you have a practitioner fit it because it can be too tight. It can cause obstruction. You may get it in and not be able to get it out. You know, I have some patients use Kegel balls. I like Kegel balls. Kegel balls are very narrow and small. So usually my patients have wider openings, not fit those, but Kegel balls are really good for urinary incontinence. Some of my patients put a Kegel ball in and they cannot pee. So you have to know how to pull it in and out. Kegel balls usually have a string, and you can find those on Amazon. And they're silicone, and they get pulled out and out. Sometimes, yeah. So if this is something you work with a pelvic floor physical therapist. I don't typically do them. They have graduated weighted Kegel balls where you know you might hold something lighter, 5 grams, 10 grams, 15 grams, and your pelvic floor muscles get stronger and holding something that's heavier weighted. I'm not a fan of it, but if you're working with a therapist, I think and you have dedicated therapy a couple times a week, I think it probably would be something that would work. I have a lot of therapists who like to use TENS units for recruitment of vaginal muscles because you'll get a little bit of electricity and all your muscles in the pelvic floor will contract. It gives your brain a signal, oh, this is where my pelvic floor muscles are. So it's a little personal biofeedback and a little bit of direction back to the muscles to help them contract. But Kegel ball, sexual pleasure, incontinence, and just to help with people's pelvic floor muscles, and that's why you purchase stuff. They're really over the counter and manage my patients themselves. But I talk a lot with them, and I go down and look for Kegel balls, some like an hourglass shape, some are little balls, some are small, medium, large. But get it fitted for your customer. Have your practitioner put it in because it can obstruct your urine. You may not be able to take it out. You know, you may find that I technically only use 2 shapes because I find everything else doesn't really work. Although I would like a little plastic molding device because I can make better custom than what's on the market, especially for some patients' vagina. But I don't have a plastic molding device. Not yet. And sometimes, you know, I have one patient a long time ago. She just wanted me to close the opening of her vagina so that she can hold the pessary. And I thought that was an interesting thought. Now we didn't talk about that. She didn't even want to rest the rest of her vaginal fix. She just wanted a small surgery. We never did it, but it was an option. I didn't put this on my slide. I can't believe this. Sometimes cervixes grow, not very often, and like Pinocchio's nose, sometimes cervixes grow and elongate. Sometimes if women have big fibroids, when the uterus doesn't come down, but you have the tissue that wants to continue to expand, and you can remove a portion of the cervix that will help with the prolapse that's all coming out. So that's something that we definitely not common, but I've had a couple of patients with very long cervixes. Yes. A cervix is routinely removed with hysterectomy these days, yes. In the past, we used to have a device called a morphulator, and so we would all open up before the prolapse, and we would open up laparoscopically, and we would leave the cervix because we technically thought, you know, even though the literature didn't show it, that leaving the cervix would decrease the risk of prolapse. For a routine hysterectomy for bleeding. Now, if you're going to do a reconstruction, some people need it. I routinely take out a cervix. It depends on if it's matched on it or not. That requires conversation. But if I'm going to do a lot of times, my go-to surgery is I remove the uterus and the cervix. The cervix is like the nose on your face, and the uterus is like your head. They're connected, but they're different organs and they have different functions, making things different. Okay, cervical cancer is not a uterine cancer. It's not a fallopian tube cancer. It's not ovarian cancer. They're all very different, even though they're all connected. Here's my nose, their eyes, right in our head. But they're different. So you can surgically separate the uterus from its cervix. There are different reasons you want to do that. Most of the time these days, because we don't morpholate anymore, in other words, we don't think the uterus has volume efficient, which is that 2 hours. We just take everything out of the vagina a lot. We go up on top, we do our whole surgery, we pull everything out and below. I have some patients who are like, I don't want to do hysterectomy. Oh, I can't do your surgery. I can't prepare an organ that's fallen out of your body if I had to take it out. I can't suspend it off. I don't do that surgery. There are a couple of people in Chicago, I think one, who will suspend a uterus. Not very common. Like one that I know. Maybe there's one, but there's only one I know. Can it be done? For sure. There are lots of people who do that. I don't. It's just not the way I was trained or what I think it makes sense in my brain.
Okay, never breakfast sleep.
One
Can't you, bring the breakfast? Like, yeah.
right. So, I wish I had this is where I need my dry case report at work. You can't see the rectum. The muscles go to the back, right? So, the vagina's in the middle, the rectum's behind me, the bladder's in front. If my rectum is pushing this way, I can't sling it that way because that's the direction it's bulging in. I need to sling it this way to keep it from coming in. To take a rectum and push it to the back means I'm coming out my butt cheeks. People used to do that, and I used to take it out. And it's bad news. They go through all the major nerve bundles and so people who didn't know how to do it, putting big devices through the muscles in the woman's pelvic. It was just a mess back in the late 2005, 7, and then in 2010, 11, the tide started turning. These women were miserable. They had all these kits of mesh and sleeves of her rectum, and they all came out their butt. And I remember seeing a guru who still does it. He's amazing. And I'm like, yeah, you can have a course, and yeah, you can do it. I can go home and do that. Watching women with 20, 30 years of experience putting in these troll cards. Doesn't make you an expert. I'm doing it. It's cute though. Someone will fly out to you flying. They're going to have great out. But in Chicago, they're not. So vaginal mesh is really falling off the wayside. So you can't sling a rectum. Although with that said, rectocele repairs, so repairs of the rectal wall, have the highest success rate and the best outcome. I actually like that surgery. I think it's a really unique part of the reconstruction of the vagina and the dynamics of pulling up that wall. So as everybody walks around, your vagina is not pointing down to the ground. Okay, our vagina is almost horizontal to the floor, a little bit oblique, and there are reasons why. That pelvic floor and the rectal wall help give you support. So women who have bad reconstruction, or bad dynamics, or whatever is happening, people in wheelchairs, walkers, when they walk like this, now your vagina is perpendicular to the floor, right? So when you have patients who are walking around and they have their little wheel cart, they're going to start prolapsing because the gravity, the dynamics of their pelvic floor have changed. And patients who can't get out of chairs and you're really going forward and pushing yourself back, salva again, holding your breath, right? Those types of things. People who have bad knees have prolapse because they're constantly bearing down to get out of chairs. So we look at all these things, and so when a patient walks into my room or I'm watching them get up to go to the exam table, all this is clicking in my head. How does this person live, right? I see patients sometimes and I'm like, well, you know, you're never gonna get better because you'll never get out of the chair and I'm trying to make them feel feet. I can do whatever you want me to do. But if you can't get out of your wheelchair in enough time to get to the walker and enough time to get to the toilet, I'm not making you content because there's not enough time. You know, so you have to look at how does a person live, right? You know, is their bathroom on the second floor, right? You know, are they constantly cold? They have to wear 10 garments. You know, people have different, habits, right? So, you have to really watch a person and, what are they doing? What are their physical abilities? What are their mental capabilities? Dementia. How many daughters I get from me and their mom? Dementia, you cannot fix incontinence. You have to be coherent. You have to have, your brain has to talk to the bladder has to talk to the brain, and it's communication. You have to be able to, communicate, to take medicine, to know the triggers of when I have to pee. And so nursing home admissions, one of the number one reasons for nursing home admissions is urinary incontinence. And I will tell you some sad stories that I had in my office. They're brutal, just brutal. Sometimes you think about, what kind of mom would she have been, or, what happened to their daughter and falling on her head, So, and if, how we treat our old patients, different conversation, it's just kind of something that's very dear to me. Just respect and dignity to people, right? We're all gonna get old. Those who are fortunate enough to make it, right? And don't die when you're young. And so just remember, not everybody crosses the street the same thing as we get older. Things change. We have to have, abilities to care for our people. And as we get older and we're 90 years old, I'm not going to do a reconstruction of the vagina for my patient. I'm sorry, I'm not going to do a 4-hour surgery. I'm not going to mention it. I'm going to go to the vagina and give her a great quality of life with very little anesthetic and very little rest. Right? So that's how I do things. I'm sorry, same-day surgery? Outpatient. Yeah, a lot of my patients go home like an hour later. I've done one under local anesthetic because she never got cleared by her cardiologist, and I was just tired of waiting. She was bleeding, she was miserable, and we talked the whole case. I told her I can't swallow my jokes. She's awake. Mom, you can't talk about. We laughed, and she went, "Oh, she did great." So I've only done one under local anesthetic because that's the challenge. I don't like my patients awake if I can help it, just because I have to do a lot of different things.
So you can't figure out a stress test?
Depending on your age, depending on your cardiac status, yes. So if you have heart disease, sometimes, you float your EKG, then you might have to have a stress test or an echo. It depends on what your risks are. I have a few patients on blood thinners for arrhythmias, right? So I have a patient who's waiting to have surgery. She's coming in December. She has AFib and she wants to get off her blood thinners. I have a patient who I'm doing surgery on very soon, and she wants cardiac. So she got to work up for cardiac clearance to do surgery a year and a half ago. Was it 2 years? She didn't pass her EKG and ended up having multiple stents, all this cardiac stuff. And so she kept, I'm getting surgery now. And then she walked another thing and look at the cardiologist, but she was so mad. I'm like, it's not my fault. It's like nothing kg, but my fault. You need to pass some kg to get more. She finally got here and then was doing the surgery. So she's very, very happy. But yeah, you have to get cleared, yes.
Hi.
Hi.
Yeah, my name's Diane. I've got probably a bunch of things going on. I just recently was diagnosed with endometrial cancer about a couple weeks ago. I don't have my surgery coming up yet, but I've got a bunch of things going on in the pelvic and abdominal area. One of the problems, besides some urgency incontinence that I've had, includes the onset of some real outstanding pain in the pelvic area. That's like very, very pronounced, clitoral, perineal, and between the perineum and between the vagina and the rectum, as well as it feels to me like maybe it's the pubic cartilage, I'm a former nurse, where it's on the sides, you know.
So you need
Yeah.
a great seat. So a lot of my patients who have the skin pain and all external pains.
Yeah.
It's a condition called lichen sclerosis.
What is it?
Lichen sclerosis, LICH.
I like the itch,
Yeah.
like tennis.
Lichen sclerosis. Anyone else can spell it.
Okay.
Sclerosis.
Yeah, I know that one.
Okay.
Okay, I have varicose veins. They are like, I can feel them working their way off my leg, getting worse. And then it seemed to me that it then got involved in the pelvic floor, the pelvic cavity.
So understand, I would not diagnose you. I'm saying that you need to have an exam to make sure that's not a problem. Sometimes I find that in the patients who have incontinence. So pelvic pain is not always just nerve endings, sometimes it's skin condition. I would broaden your thought process to that. In terms of your varicose vein, it'll just depend on what's happening, you know, with your cancer. So that just changes the whole thing. So in areas that I'm not comfortable, you know, explaining because it's not real.
When I said there was a bunch of things going on, that's kind of what I was referring
Very
to,
complicated.
is because the venous issue. Now, my care is actually at Northwestern. I got 2 postcards from them. One was from the Urogynecology Institute, and another one was from the cardiovascular. So there was 2 different places that were looking at pelvic floor pain, and it was at each of those institutions. I did see a regular gynecologist, a surgical gynecologist, an oncology gynecologist, etc. And so they had told me that I needed to see a urogynecologist, and between the time that I'm going to be scheduled for my hysterectomy she wants to do, I don't know that I'm going to be able to see a urogynecologist, which the oncologist had told me that the hysterectomy to get rid of the cancer may not cover the other pain that I'm experiencing, and that's why she put me in for a consult to a urogynecologist. And as I said, I may not have been able to see one of those before the surgery, but I didn't know what direction I should go in to tackle that, since it's more than one body system. And when I saw, my brother is a cardio patient over at Christ, and so when I came out after his thing, there you were. And I thought, man, God provides, and that's what it's, Christ Advocate Hospital. So I thought, you know, I signed up right then and there, and I was going to see what I could find out here, because as I said, I don't know if I'm going to see a urogyne before my surgery, and I thought that there was going to be maybe a pivotal point in what I might need for treatment.
As a urogyne, I would think that you have your cancer surgery medicine. Because, you know, it just depends on, you know, tumors pressing on nerve endings that can radiate and take care of these areas. There's nothing surgically I would do as a urogyne until you recover and solve kind of what your baseline. Because sometimes you do things that may not be helpful. So I would probably wait. And then in terms of pain, a lot of my patients are talking to use ice, but you know, just follow with your gyne on. But you can definitely use ice pack there. In terms of your vascular flow and your varicose veins, I don't know how that plays into it because you're not my patient and it's really hard for me to talk about that on the line. I'm not an oncologist, but as a urogyne, I always step back and I let my patients take care of my aunt. And then after has finished their workup, that's most important, that's what's gonna, improve their life, then that patient will come back to me. And then I'll take over for what I need to do, but, just depends. But it's hard to say what your symptoms are that are not being caused by cancer versus being caused by something else. And bar none, your cancer gets taken care of first.
Yeah, that hasn't been staged, but
It's not gonna get staged until it comes out
right.
and you have surgery. And so those decisions get made, afterwards, unfortunately. It's really hard to predict a lot of things.
I was trying to maybe like head off the pain because I know with the hysterectomy, there's gonna be that. And then I wasn't looking forward to having that on top of the other pelvic pain.
Sure.
To tell you the
Sure, it's complicated.
Yeah, and do you know, as far as like treatment for the pain? Is there?
It's really hard for me to give you an opinion specifically on your situation.
Yeah,
And I'm gonna tell you that I'm not gonna do that. One, because you're not my patient, it's not appropriate for you with medical advice. Two, I've never examined you. Three, it's kind of not about the lecture and the prolapse.
Yeah.
So if you need to have an opinion made, then I think you need to call my office, or you need to call the gynecologist if one question, because it's really too specific right now to talk in this forum.
I didn't hear anybody mention for treatment CBD.
For prolapse?
No, I didn't know that was the basis of this lecture.
Yes, it's pelvic organ prolapse. So I'm giving a series of lectures. Oh, I'm sorry, I know what you mean. Right. You saw pelvic organ disorder.
Yeah.
So this one, the one I gave earlier was on continence, this was on prolapse. I gave one on sex, and what's my last one on? I forgot. Hormones. So then we circle back into hormones again, but I don't talk about pelvic pain in any of my lectures. And I think your situation, even if I was, your situation is so unique, you really need a thorough evaluation to get an opinion. It's not the forum to give an opinion on a specific medical issue. I'm sorry. And I understand frustration and pain, because pain is a complicated issue. But it's so unique, it's very difficult to kind of tell you and pain, and you have to test it,
I didn't think of that until somebody else asked about Botox.
Yeah.
About the
So,
pain.
yeah, and Botox can be used for pelvic pain, but, and I use it, it's off label, you have to pay for it, it's very expensive, $10,000. And it's not FDA approved for that indication. We use Botox for migraines, muscle spasticity, cerebral palsy, angle, and, urinary incontinence.
So no CBD as far as pain goes for.
Those are,
we'll talk
yeah,
about.
pain is not what this lecture is about. CBD is not my area of expertise, and I don't know. Illinois is, buying the products, I think, you just showing your driver's license at any dispensary. So you can try whatever you want. I mean, I know they're very, I know when you go into a dispensary, you can talk to them and they can kind of do like different strains and stuff for different symptoms. So if you're a practitioner, you get a medical marijuana license from your physician for pain. And again, that is a conversation you have with your provider and whether or not that's something that they provide.
Back, when I inhaled, I knew women who used regular marijuana because they said it helped their cramps.
Sure. People use all sorts of things, I mean, there's a plethora of over-the-counter, not over-the-counter, legal, illegal things for pain, right? People do all sorts of things. I'm not sure how else to help you with that, so you really see a physician.
Okay.
I'm sorry.
That's okay.
Any other questions on prolapse? I'll have to bring my models next time now that we've figured out our audio visual. Yes. Oh, yes. Yes, thank you. No, I didn't put that in my slide. You're absolutely correct. I should add that. Obesity is definitely a risk factor for prolapse. Although there are some studies that show, The surgical outcomes in patients with lower body mass index or, less weight and high weights all have the same surgical outcome. In my experience, the heavier you are, the harder it is to recover and have sustainable outcomes from surgery, and sometimes you have more prolapse, but it's completely varied. I mean, I have a very diverse population. And I think when you talk about, obesity as an impact to prolapse, it's more about body mobility, right? And some people, are very overweight and yet run across the room. And some people need to be on a walker because their knees can't support their weight and may not be morbid obesity, than just obesity. So it just depends, but definitely it's a risk factor. But I have a lot of, normal body weight patients with prolapse. I have a full range. I don't find that it's predominantly obesity. What I find is predominantly child and work and constipation. Those are the three things. What do you do for a living? How many children did you have? And how constipated are you? The biggest factors. And what can we change? We can change our job. We can change our constipation. What did I say? I was just thinking, I had a patient who came to me, and I was a little bit upset because she wanted disability papers for a job she was about to get. She didn't get the job. And she's like, but don't give me my paper for now. I want to get the job first. Then give me the paper that says you can't lift because the job has heavy lifting. Well, maybe I shouldn't get that job. But I don't know, like, it's not cool this happens to me. Right? And I thought, you're going to be partnering this with grand family, it's not going to happen. So, people know everything. Squats. Nobody squats for anything. Great question. So, again, when you go home, everybody, I want you, when you poop, I want you to see how you hold your breath. When you're exercising, you're going to do a squat first, I like to work out. It doesn't look like it, but I do. Your knees should be above your ankles. So everybody squat and their knees are like this. They're like, oh yeah, I got a great squat. That is the wrong squat. A squat is like you're going to sit to the back of the chair. Yeah, the friends are going like that. That's a squat. So everybody go like this and then they hold their breath and you back up. And then you want to do it with kettlebell, right? And you're just holding your breath. And all you're doing is bearing down. Just make your prolapse worse. I think they should have public physical therapists in every gym because I watch them all the time. Why would not be doing that, right? They're like, leg presses. I'm like, wait, the more you run, the more definition on your vagina. And I should have something good news for everybody, right? And post it up on the bathroom walls. Out the bottom bars too. I should have like, little, no, I should just have a comedy. There's this with two brothers, everything in my house was funny, everything. But really, women don't, they don't think because they don't know. But, when you do your exercise, you never hold your breath. And your butt goes towards the back. If you're going to do leg presses on the leg press machine, don't hold your breath. Breathe through it. If you're going to do arm curls, whatever you're going to do not hold your breath, ever. The moment you hold your breath, all of the pressure goes down and opens up the vagina. And over and over and over and over again, you get prolapse because all you do is push your uterus out. It is a deficit. It is an opening. It's an area of weakness in the woman's body. So you don't want to put that under any stress, right? Okay, so you want to walk upright if you can, even if you're using a walker. You want to maintain normal body weight if you can. You can't change your genetics, you can't change your getting older, you can change your constitution, you can change your job, you can change whatever you can stop holding your breath. If there's anything you take home, stop holding your breath. Breathe through everything and don't get constipated. Right? And we should have trainers at the gym. It would be nice, it would be really beneficial to have a public physical therapist and show you. And I tell my patients after surgery, you're not going to physical therapy to help prevent the prolapse in terms of like my surgery as much as to change the way you live so that you don't do what got you here to begin with. Because there's something that you're doing that made you have the prolapse. Like podcast. You want to do physical therapy, so you learn how to move, how to walk, how to work out, how to change your diet. You do bowel massage too for constipation. Let's do a constipation toothbrush. Okay, it's fine. I see where I'm kind of goes. That's how we end it, right?
Our Kegels strengthen and have it.